All right, we are recording now. Also, if you haven't noticed, last Friday's lecture I posted on lecture 20 and 21. So I just posted it twice so that you wouldn't be confused. Of course, you don't have to watch it twice, but just know that they're in two different places. All right, so let's see. 82 students have responded. How many of you need a little more time to respond to this particular question? Pretty good? All right, so the correct response is C, myocardium. All right, great. 93% of you all got that right, so that's wonderful. All right, so today what we're going to be doing is we're going to finish up with electrophysiology of the heart. This is one of those lectures that is, there's a lot of information. It can be more abstract, so please ask questions if there's anything that's confusing to you. I think we'll have enough time today to get through the entire lecture. Now, I have this lecture open. It's lecture 9 at the top. It is posted on your website, just so you know. I think I'm going to pare this down. This has both lecture 21 and the back end, which is what I'll do is I'll clean it up a little bit on our Canvas website. Today it'll say lecture 21A and lecture 21B. Right now, lecture 9 is a compilation of both, okay? So here's where we're going to start. We talked about this last time. We talked about the electrical current that sweeps through the heart last time. What this is are action potentials that fire within each cell, and the depolarization wave goes from cell to cell to cell through gap junctions, okay? So this is how that electrical signal sweeps through the heart, and just like skeletal muscle, remember the electrical event happens first and then contraction of the heart, okay? So this is excitation-contraction coupling. I had a student in my office just last Friday, who was asking about putting it all together. This is what you'll need to do at home, right? This is the synthesis. You're learning things in a very compartmentalized way. It's your job when you get home now to put it all together, okay? All right, so we started, the electrical current starts in the SA node itself. These are expressing something we'll learn today called funny channels. They are literally called funny channels. And we'll talk about that, why. It actually causes an eroding depolarization. It doesn't have a nice steady resting membrane potential like most cells. It erodes until you reach threshold, and then it fires an action potential. That's why these are called the pacemaker cells. They're expressing funny channels, okay? Then that depolarization wave sweeps through both atria until it reaches this atrioventricular node, or AV node. And because there's not many gap junctions, the signal slows down in the AV node, allowing enough time for the atria to completely contract together before that electrical signal runs through the ventricles. So it slows down in the AV node, then it arrives at the bundle of His, the left and right bundle branches. You can see that in yellow here. These are special fibers that allow for that electrical current to run down the septum of the heart to the apex. Talked about the apex last time. It's the bottom of your heart. And then it runs up the Purkinje fibers, and then don't forget that then it sweeps through the ventricles, those myocytes. That's the last thing. And that's not on this slide, so don't forget that the ventricular myocytes depolarize after the Purkinje fibers. All right, so let's see here. I'm going to skip to this one right here. This is actually what you see, right? The atria now contract, or I'm sorry, they depolarize. You can actually see the yellow atria. slows down in the AV node, then runs down the left and right bundle branches and up the Purkinje fibers, and then you actually see the ventricular myocytes completely depolarize. They're all in yellow here. Now remember, the repolarization will follow the same path. So the SA node will repolarize first, then the atria repolarize, then it goes down the AV node, left and right bundle branches repolarize, then the Purkinje fibers, and then the ventricular myocytes repolarize. So repolarization will happen in the same pathway. It'll just be a little bit of a lag time. Depolarization first, then repolarization. All right, just as I talked about before, here are the conduction velocities of each of those fibers. And all I really want you to notice is the atria and the ventricles, they have about the same speed of contraction. Or I'm sorry, not contraction, conduction. So the conduction velocity are the same, about 1 meters per second. His Purkinje fibers, this is the bundle of His, the left and right bundle branches, and the Purkinje fibers. They're a little bit faster. The conduction velocity or speed is 2 to 4 meters per second. But please notice how the AV node really slows down. Okay, about 100 times less than what happens, the conduction velocity in the atria. 0.01 to 0.05 meters per second. So again, there's not many gap junctions in the AV node. That's why that signal slows down. It's important to note too that that slowing of the conduction velocity in the AV node allows for the atria to completely contract before the signal, the electrical signal, travels through the ventricles. So just like with skeletal muscle, excitation happens first, and then you remember calcium has to be released, it binds to troponin, moves tropomyosin, and then contraction. Okay, so that's just like what we talked about with the skeletal muscle. All right, so here's something too that I want you to understand. Once that electrical signal runs to the apex first, and then up the Purkinje fibers and the ventricular muscle, what that does is it allows for an upward sweeping motion when the ventricles actually contract. An upward sweeping motion to help propel the blood out into the aorta. Okay? All right, moving right along. Okay, so what we're going to do now, here's a source of a lot of confusion. So I want to take some time and make sure that you see the distinction between action potentials within the heart and now how to think about the ECG. Again, if you're going into any kind of health profession, nutrition, vet school, med school, PA school, wherever you're going, physical therapy, everyone needs to know something about the ECG. This is the electrocardiogram. Okay? So I want you to see that the action potentials are, this is the measurement you would make if you impaled one cell within this particular area. This is the SA node. So if you took an electrode and you just impaled and you're just measuring that inner leaflet, you're going to see an eroding depolarization in the SA node, reaching threshold, and then further depolarizing, and then repolarizing. Okay, so that is the measurement you would make in one cell within that patch. Okay, in the ventricular muscle, this is the ventricle, this is the myocytes in the ventricle. If you impaled one cell, you would see a more stable resting membrane potential. And then once those graded potentials came through the gap junction, you'd see a rapid depolarization, followed by a plateau phase, repolarization. So we talked about this last time. Remember that the refractory period, or the depolarization of those cells, lasts as long as the contraction itself. So you know these terms now. So it stays in refractory period for a much longer time than, say, neurons, to make sure that the heart can't reach summation and tetanus. That's the last thing you want. You don't want your heart to cramp up. So this is a very long depolarization phase. That's what happens if you impale one cell within the ventricular myocyte. Okay, so what is the ECG, right? Some students get the ECG mixed up. They think that's an action potential, or vice versa. They think the action potentials are the ECG, right? So I want you to see that the action potentials are kind of looking at the microscopic level. You're just looking at one cell. But pull out, and the ECG is what's happening in the heart as a whole, okay? So you can see this is all color coordinated. This is actually called a Netter diagram. It cost me, when I first started teaching, $100 for this one slide. But it was well worth it. I've been using it for about 12 years now. So what you have here is each one of these action potentials occurs in different parts of the heart. And you can see it's all color coordinated. So if we're talking about the SA node, then this is what the action potential looks in the SA node. And this part of the action potentials is represented in the very first part of the P wave. Okay, it's blue right there. I can even blow this up a little bit if that helps. Maybe? Oh, right here. Okay, so you can see the very first part of the ECG is that blue part. That's the depolarization in the SA node. Most of the P wave is the depolarization that happens in the atrium. That's atrial depolarization. And you can see that makes up most of the P wave. AV node is the yellow part here. So what this is the ECG is looking at the heart as a whole as the action potentials sweep from cell to cell to cell. You're pulling back and you're seeing how all those action potentials sweep through the entire heart. So the P wave is actually atrial depolarization. It's got a little bit of SA node and AV node, but it's mainly atrial depolarization. Okay, so the gray part makes up most of the ECG. The QRS wave, which is ventricular depolarization, and the T wave, which is ventricular repolarization. All right, we'll talk about more of that in just a second, but I wanted to explain this slide. I'll go into more detail in a little bit. All right. So first, before we go into the ECG, now you have kind of a good idea of where we're going today. Let's talk about the action potentials first. All right, the only two that I want you to know for the exam is the ventricular muscle action potential. You already know something about that. And what happens in the SA node. These are the two extremes. So let's just zoom in on each of these cells. This is a microscopic look at just one cell itself. And let's first talk about the ventricular myocytes. You'll notice again, the ventricular myocytes have this plateau phase. It's an extended depolarization phase that corresponds to the refractory period. Remember, refractory means no matter how strong that second stimulus, you can't fire another action potential when the cell is in its refractory period. So again, you can't reach summation or tetanus. It lasts as long as the muscle contraction to prevent cramping of your heart, prevents tetanus. All right, so again, what we're going to focus on today is what happens in the ventricular myocytes, that's A, and in the SA node. Don't worry about the atrium. We're just going to take the two extremes. So let's talk about this. Again, this is the ventricular myocyte with the prolonged plateau phase. And I want you to understand these different phases of the action potential. You actually have a rapid depolarization phase called phase 0. 1 is this tiny little dip here. 2 is the plateau phase. 3 is repolarization. And 4 is the resting membrane potential. All right, so also please notice the equilibrium potentials and remember the chord conductance equation as I'm going through this. Remember, it's all about the relative conductances. If we're talking like, say, only sodium and potassium are moving across the membrane and the two conductances are 50-50, remember the membrane potential is going to be about halfway in between. As you increase the relative conductance for sodium, you're going to pull the membrane potential closer to that equilibrium potential for sodium. Same with calcium. So anytime you increase the conductance of sodium or calcium, you're going to get a profound depolarization. Anytime you increase the conductance for potassium, you're going to get repolarization. It's going to pull the membrane potential back down closer to the equilibrium potential for potassium. So again, these action potentials, the action potential waveform is due to the expression of these ion channels, right? And how they open and close with changes in membrane voltage, just like we've learned before, okay? So this rapid depolarization phase, phase 0, is due to the opening of voltage-gated sodium channels. So it's triggered by the graded potential that enters through the gap junction. That depolarization wave goes from cell to cell. So a graded potential enters into the cell. It triggers the voltage-gated sodium channels, and then you get this rapid depolarization phase. 1 is actually due to a transient potassium channel. It slightly repolarizes the cell. But then you get these calcium channels that open, and they're responsible for the plateau phase. Voltage-gated calcium channels. You can see that right here, calcium. And then the potassium channels open up. Those are the delayed potassium channel, and it repolarizes the cell. And then the resting membrane potential is due to a potassium channel as well, and it sets the resting membrane potential. So it makes sense if you're looking at the equilibrium potentials and you know these channels are opening, right? The change in conductance is going to pull that membrane voltage towards that equilibrium potential. All right, so let's go through these set of slides. It's just basically saying the exact same thing. This bottom slide right here is giving you some idea of permeability or conductance. Permeability or conductance. So when the voltage-gated sodium channels open, you can see the permeability really rises, and then the voltage-gated sodium channels inactivate. So that's what's responsible for this rapid depolarization. The rapid, and here's some text if you need to have it. The rapid opening of a voltage-gated sodium channel is responsible for the rapid depolarization phase. Then this actually skips to the plateau phase. That's in purple here. That's due to the opening of a voltage-gated calcium channel. So the prolonged plateau phase is due to the slow but prolonged opening of a voltage-gated calcium channel, plus the closure of a potassium channel. So if it's closed, that decreases the relative conductance of potassium, keeping it at a depolarized phase, that plateau phase. And then finally, those delayed potassium channels open, and the opening of the potassium channels results in the repolarization phase. So I started with the ventricular myocytes because they have all 5 phases, 0, 1, 2, 3, and 4. Okay, so why do you really actually need to know that there's these different ion channels that are responsible for the action potential waveform? It's important to know that because as you get into the clinics, there are some important anti-arrhythmic drugs, class 1, class 2, class 3, right? Class 1 are inhibitors of the voltage-gated sodium channels like lidocaine. That changes the action potential waveform. It helps with arrhythmias. Class 3 are the potassium channel blockers like amiodarone. Maybe you've heard of that before in the clinics. But you know that it's these anti-arrhythmic drugs that are actually targeting these different ion channels that can change the action potential waveform. Okay? So something to think about when you're in the clinics. That won't be on your test, right? What will be on your test is what channel is responsible for phase 0? What channel is responsible for phase 3? The voltage-gated sodium channels are responsible for 0. Voltage-gated potassium channels are responsible for phase 3. Okay, just something to think about too. If there is a channelopathy, let's just say channelopathy, and essentially there's something wrong with the voltage-gated potassium channels, let's just say. There is a blockage, or there's not as many potassium channels expressed. That will prolong the action potential waveform way out here so that, right, repolarization doesn't happen so quickly. And let's go back to what that's going to do is it's actually going to prolong the T wave. So, for instance, you can see the time course of that action potential within each cell corresponds to the QRS, which is ventricular depolarization, and the T wave. See how that corresponds with the repolarization phase? If you have something wrong with the potassium channel, that's going to increase the duration of the action potential and push the T wave way out here. This is something called long QT syndrome, if you've heard that before. Long QT syndrome. Long QT syndrome can cause what's known as sudden death syndrome. It's one of those events where you might have an elite athlete out on the basketball court and then all of a sudden dies suddenly, right, with exertion, exercise. A lot of times they find that those patients actually had long QT syndrome that caused an arrhythmia. Okay, so again, that's not going to be on your test. This is going to be very straightforward, very basic. I'm just asking you basically what are the different ion channels that are responsible for each of the different phases. All right, so let's move on to the SA node. Here's where we get into our funny channels. The funny channels are actually called HCN channels. Let me show you what that is. HCN channels. I'll blow this up so people can see this a little bit better. Oops, my pen isn't working. Sure beats, good. All right. HCN. That is hyperpolarization. They don't activate until the membrane is hyperpolarized. Hyperpolarization, cyclic nucleotide, gated channel. So the cyclic nucleotide it's gated by, it's actually altered by cyclic AMP. You guys know that with the GI and GS pathway. And these are literally called the funny channels. And this was more funny strange, not funny haha, because it looked strange. It was a very strange channel. All right, these are known as your pacemaker channels. So let's go back. Everybody have that down? Funny channels. These are responsible for the spontaneous depolarization here. So they open at hyperpolarized voltages. This is where they start to open, at hyperpolarized voltages. They're a non-selective cation channel, just like the nicotinic acetylcholine receptor. So it allows for both sodium and potassium. So you get this eroding, slow depolarization. That's the funny channels. And then it reaches threshold. Phase 0 are calcium channels. So don't get that mixed up with phase 0 of the ventricular myocytes. This rapid depolarization phase is due to voltage-gated calcium channels. And then phase 3. So there's really only 3 phases for this action potential waveform. Phase 3, you could probably guess, is due to potassium. Potassium repolarizes the cell. That then opens up the funny channels once again at hyperpolarized voltages, and then you get this slow depolarization until you reach threshold. Voltage-gated calcium channels open, and then the voltage-gated potassium channels. All right, same idea here. A little bit more information. These pacemaker cells of the SA node are derived from cardiac myocytes, but they've differentiated. The major difference is they have small, few myofibrils, so they don't contract. They don't have myofibrils, mitochondria, or other organelles. All they do is depolarize. These are your pacemaker potential. So, that first phase, that phase 4, is that eroding membrane potential. Sodium ions leak through these funny channels, plus the calcium channels move in through T channels. These are transient channels. But just for our purposes, just remember that the funny channels open at depolarized voltages. The rapid opening of voltage-gated calcium channels are responsible for phase 0. This is different from the ventricular myocytes. In the SA node, it's due to voltage-gated calcium channels, and then the repolarization is due to potassium channels and the closure of the calcium channels. All right, so I have this movie for you. I really like it. It's a computer simulation of how the depolarization wave propagates through the heart. Actually, it's just the SA node, which is this tiny patch of cells here. And the green is the atrium. Okay? What you're looking at on the left-hand side here is membrane voltage. So when it's very hyperpolarized, you'll see a red color. And when it's very depolarized, you'll see this purplish color. All right, so this is a nice, you see this eroding depolarization. Atrium is very hyperpolarized until it reaches threshold and boom, propagates through the atrium. The SA node never really gets too hyperpolarized. You've got the funny channels open now, slow depolarization, and then it sweeps through the atrium, right? So this is a simulation of how this goes from cell to cell to cell and then sweeps through entire parts of the tissue. Okay, pretty cool, pretty cool. I like that simulation. It kind of really highlights how that depolarization wave goes through the heart. All right, back to our okay, so just remember a single myocyte, cardiac myocytes in culture spontaneously depolarize, and it exhibits what's known as intrinsic automaticity or rhythmicity. This is called, the muscle itself is myogenic because the signal, the depolarization, starts within the muscle itself. Okay? Differences in cardiac action potential waveforms reflect the distinct patterns of ion channel expression. The reason why you get that eroding depolarization in the SA node is because the SA node is expressing the funny channels. Okay, so let's kind of go back and take a look at the ECG again. ECG. All right, so to start off with, students in the lab are actually going to get a chance to do their own heart waves here in the next couple weeks. What it is you actually take electrodes and you put one on your left wrist, one on your right wrist, and one on your ankle. It makes something at the bottom there you can see on the screen called Einthoven's triangle. Einthoven's triangle. So if I extended my arms out, you can see that actually makes the triangle. What I'm looking for is, with the ECG, those electrical, the action potentials as they sweep through the entire heart, right, just like I showed you before. You can pick that up on the ECG, the electrocardiogram. So it's looking at changes and depolarization waves as it actually sweeps through the ventricles now, okay? Here's what I've already talked about, but if you need some text associated with the P wave, QRS, and T wave, remember the P wave is atrial depolarization. Kind of, you can see that down here, P wave. QRS is ventricular depolarization, and then the T wave is ventricular repolarization. What do you think happened to atrial repolarization? What happened to it? When you think about the time course, what could have masked it? I know it's Monday. Everyone's super tired. What's that? QRS. Yes, right? The QRS is so large that it actually masks atrial repolarization. Okay? And why is the QRS so large? It's because the ventricular muscle is the largest muscle mass within the cell. The largest muscle mass. So the QRS is just huge as a result. So why does the P wave and the T wave look essentially the same? They have the same blip. I'm going to go to the document camera here for a second, and like I said, I can't draw a heart, but I'm going to draw a Valentine heart that looks like that, right? And we've got our atria and our ventricles. So depolarization starts in the SA node, and it sweeps through the atria in a very particular direction. So Really, the QRS and T wave is looking at how the action potentials sweep through the heart in a vectoral manner. That's in a particular direction. So depolarization starts in the SA node, sweeps through the atrium, down the ventricular myocytes, the septum, up through the Purkinje fibers, and up through the ventricular myocytes. So the atrial depolarization is responsible for the P wave. Then the QRS, you can see that the depolarization goes down and up the ventricular wall, so that's the QRS wave, right? QRS. And then the T wave is repolarization. So remember, repolarization is going to follow the same path, and as it sweeps up in this direction, you can see that, here I'll do the, sorry I can't get it all in one here. The P wave, depolarization in one direction, looks exactly the same as repolarization in the opposite direction. That's why the P and the T wave look very similar. Want me to say that again? Depolarization in one direction, that would be the P wave, looks very similar to repolarization in the opposite direction. All right, so now you can see how this is all coming together. Know the difference between action potentials, which is really looking at the membrane potential, the changes in membrane potential in one cell. Now the ECG is looking at all of the electrical activity in the heart as a whole, as those action potentials sweep from cell to cell to cell to cell. Okay, any questions? Pretty good? All right. So moving right along here, let's take a look at some typical, here's some typical ECG data. What you'll notice at the top here is this is a normal sinus rhythm, right? Normal sinus rhythm. P, QRS, T wave. P, QRS, T wave. Okay? Now, if you have a partial block of the AV node, a partial block, what you'll notice is not every P wave will lead to a QRS, right? So you have a P, QRS, T, then there's a block at the AV node, P, nothing. P, QRS, T, P, nothing. This is indicative of a partial AV block. C is a complete AV block. Now the P and the QRS are actually firing completely separately. What you didn't know is the AV node has its own funny channels. It can be the pacemaker. All right? So now the P wave is, see, the P wave is firing completely independently. You can even see a P wave right in between a QRS and T. And the AV node has taken over as the pacemaker for the ventricles. It's very slow. Patients that come in with this are usually have a profound bradycardia, which is a slowing of the heart. And so now the AV node taken over as the pacemaker, you get a QRST. Way down here, QRST. Again, the P wave and the QRST are completely independent of each other. So a couple of more terms here. Bradycardia. This is a profound slowing of the heart. Slow heart rate usually lower than 40 beats per minute. The opposite of this is tachycardia. Tachycardia, which is a rapid heart rate. And these are both at rest, resting heart rates. Rapid resting heart rate, usually greater than 100 beats per minute. Bradycardia, tachycardia. So again, patients that come in with a complete AV node block usually present themselves with bradycardia because the AV node has taken over as the pacemaker. All right, some other interesting traces. A lot of times with individuals that have suffered a heart attack, they call that the widowmaker. Usually it's a blockage of the left coronary artery. Instead of a PQRS wave that looks like this, they present themselves with an elevated ST wave. So it looks like this, which again could be confused as an action potential, but it's an elevated ST, PQRS T. This is a heart attack or myocardial infarction, heart attack. Usually due to the blockage of a left coronary artery, doesn't bring oxygen and nutrients to certain parts of your heart, and it causes what's known as ischemia because those cells die. To remember this is a lot of times what vet school, med school students remember. This is also called the fireman's hat or the tombstone wave. Yikes. Remember, these are the widow makers, but it actually helps you remember that waveform. Now, I've seen a commercial on TV. You can get little electrodes on the back of your iPhone. You can put them on the back of your iPhone. Put your fingers there, and you can see your heart rate waves, ECG. Everybody can see them now. So it's pretty cool, pretty cool. All right, so back to our slides here. The relationship between the electrocardiogram, ECG, recorded as the difference between currents at the left and right wrists, and the action potential within each myocyte, ventricular myocyte. Notice again that the time course is very much the same. The QRS is ventricular depolarization, and the T wave is repolarization. So note that those are, the time course is the same, about 250 milliseconds. So putting it all together, looking at how the electrical current sweeps through the heart, you can actually see how that applies to the ECG. All right, so how are we doing? Oh, we're out of time. Okay, that's good for today. That's all I can do for today. All right, I will see you all on Wednesday. Wow, that went fast. If you have any questions, come on up. We can discuss some of these concepts after class. Have a good Tuesday.
Hey, hi. Some of the slides, I printed off the slides we had online, and I think some, like those I don't have the last couple.
Yeah, so those are in lecture 9.
Oh, they are?
Yeah.
Okay.
Okay, so what I'm going to do is clean this up. On Wednesday, I will talk about the autonomic nervous system and pacing, but it's going to be very short.
Okay.
So just hang. When you take a look, when you take a look at it, this afternoon. It should be all cleaned up.
Okay.
And I'll make sure that A has all the slides, and then B has the stuff on Wednesday morning. Hi, Magna. How are you?
Okay.
Does that sound okay?
Yeah.
And I don't want it to be confusing.
For the review session, I was able to make it to the last one, but I'm not sure I can come to this.
Sure.
Do you usually record?
I do.
Okay.
Did I post that last time? Yeah,
I don't remember, but
yeah,
I'll
I did.
remind you
Yes.
if you don't.
Okay,
because
yes.
it was awesome. So I would like
The
to.
other thing is there's already a recorded review session from last spring.
Okay.
And so if you want to take a look at that ahead of time, you can. But I will record the one on Friday.
Okay, perfect.
Yes.
All right, thanks. Otherwise, I'll try to make it. But
Okay, sounds good.
you.
Yes. Hi, Olivia. How are you?
Good, how are you?
Good.
So I had a question about the P wave
Yes.
and the T wave.
Yes.
So if one is depolarization and the other is repolarization, why do they both look like
Exactly the same.
Yeah.
Yeah. So depolarization sweeping through the heart in one direction
Yeah.
is going to look exactly the same as repolarization in the opposite direction.
Okay. But why does it always have the peaks? Because wouldn't
Okay.
repolarization go under?
I see. Not if it's going in the opposite direction.
Oh.
So you're just
increasing?
Yes.
Oh,
Yeah. So
okay.
really, this is just actually looking at how the electrical activity sweeps through the heart in a very specific direction. Because remember, you have electrodes on your wrists
Yeah.
that are just measuring it in a very specific direction. So again, if depolarization is sweeping through the atria in this direction, then repolarization in the ventricles is sweeping the repolarization as each cell repolarizes. That repolarization wave going in the opposite direction is going to look exactly the same on the ECG.
Okay,
Yeah.
that makes sense.
Yeah.
And it's because of the values then?
Yeah, it's
Okay.
pretty much the values. Yeah,
Okay.
a lot of times the T wave can be a lot larger than the P wave. It really depends on how you're positioned, how your heart is actually positioned too in your body. But the electrodes, a 3 electrode lead is not that great.
Okay.
Usually in the clinics you would do a 12 lead, which gives you a picture of the heart as it kind of rotates around. And you can kind of glean different information depending on. But what you're looking at again is that vectoral movement as those action potential sweeps from cell to cell to cell in a very specific direction.
Okay,
Yeah.
that makes sense.
Yeah.
Thank you.
Okay, you're welcome.
Alright, so we just had a few questions about
Yeah.
our group project.
All right.
So we're thinking about doing like a Monopoly game sort of thing to like present our information.
Yes.
So we're wondering, do we still need to make like a video?
No. I would just say if you bring me the game, the set of instructions, in a box, whatever, I can look at it that way. So don't feel like you have to do a video.
Well, then we're
It's
just
not a
wondering 'cause-
presentation.
Okay, so we don't have to present in front of like a classroom?
Nope.
Oh.
I may actually, other students are going to want to look at everybody else's. If you just take some pictures and of the instructions and kind of take some pictures of the games too, I can put your folder. They'll just click on the folder and then they'll see your game. And if you can explain it that way, that's fine. Everybody's going to be a little curious about what everyone else's projects are about.
And then as far as timeline,
Yeah.
is it just December 16th?
Yep.
Is when we have to have it turned in
Yeah,
by? That's
you
it?
have the entire semester to do it. Yeah, no problem at all.
Cool.
Yeah.
Alright, thank you.
Yeah, thank you.
Thanks.
Hi. I'm just going to turn this off real quick before I forget. Okay.